Every parent dreams of the perfect child: 10 tiny fingers, 10 tiny toes, a healthy heart, a healthy brain, and then a small gap in the lip. In a single moment, joy gives way to fear. Questions begin to fill the room. Will my baby be able to feed? Will my child speak normally? Will they go to school? Will they smile with confidence? Will they have a normal life? But perhaps the biggest challenge isn't the cleft itself, it's the fear, the stigma, and the misinformation surrounding it. Because a cleft lip or a palate is far more than a difference in appearance. It can affect feeding from the very first day of life, speech development, hearing, dental growth, confidence, and the way a child is accepted by the society. And yet, with timely treatment and the right team, these children can grow up to speak confidently, pursue their dreams, build successful careers, and live lives no different from anyone else. In this World Cleft Day special of Rebooting the Brain, we are joined by Dr. Krishnamurthy Bonanthaya, one of the India's leading cleft and craniofacial surgeons who has dedicated more than 2 decades to transforming the lives of children born with cleft lip and palate. His work extends far beyond the operating room. Today, he leads one of the world's few cleft leadership centers at Smile Train, bringing together surgeons, speech language pathologists, orthodontists, nutritionists, psychologists, ENT specialists, anesthetists, and rehabilitation professionals to ensure that every child receives complete compassionate care. Because repairing a cleft is not the work of one surgeon, it takes an entire team. In this conversation, we explored the complete cleft journey from diagnosis during the pregnancy and the difficult decisions families often face, to the first hours after birth, feeding challenges, stage surgeries, speech development, confidence, and life beyond treatment. We also confront the myths and the misconceptions that continue to surround cleft care, some so deeply rooted that they influence life-changing decisions even before the child is born. Through remarkable patient stories and decades of experience, Dr. Krishnamurthy reminds us that a cleft is not a limitation, it is a condition, one that can be treated, one that should never define a child's future. Because perhaps the greatest transformation is not the one that happens in the operating room, it is the one that restores hope to a family. From fear to confidence, from stigma to acceptance, from surgery to second chances. This is a conversation about restoring far more than a smile. This is Rebooting the Brain, and this episode is a reminder that every child deserves more than a perfect smile, and they deserve every chance.
ജ്ഞാനാനന്ദമയം ദേവം നിർമ്മലസ്ഫടികാകൃതിം ആധാരം സർവവിദ്യാനാം ഹയഗ്രീവ ഉപാസ്മഹേ ഹയഗ്രീവ ഉപാസ്മഹേ.
Rebooting the Brain, powered by PRS Neurosciences.
Namaste, everybody. Welcome to one more episode of our podcast, Rebooting the Brain. First of all, I want to thank all of you who've been such, big supporters of our channel, the kind of views that we have got, the subscriptions, the comments on all 3 channels, Instagram, Facebook, and YouTube, of course, and all the shares that you have done. So thank you very much. You are the ones who inspire me and us to do more and more work to get more quality content to you in a way that all of you understand, because we want this unfiltered to go out. And for all of you who do not know, all the episodes you have seen so far, there have been no edits. What we shoot is what you see. That's why it feels like a conversation and not like an interview. Before I start on today's topic, some housekeeping rules. Don't forget to subscribe to our channel. YouTube, Facebook, Instagram. Hit the like button and definitely share it with people. And don't forget to put your comments. Your comments are very critical for us to get these people to push it to more and more people, and that is what is helping more and more people get quality content that is there. Today with us, we have a very important person. And before I introduce him to you, we'll do the shloka. Om Asato Ma Sadgamaya Tamaso Ma Jyotirgamaya Mrityorma Amritam Gamaya. Om Shanti Shanti Shanti. This shloka has been an inspiration for me from my childhood. And as the shloka says, from ignorance to enlightenment, from darkness to light, and from death to immortality. You can use this shloka anywhere in your life, personal or professional, and see how it benefits you. Such a simple thing. Try it, guys. You will not regret it. And today we are going to talk about a very important topic on this I won't say special, on an important day called the World Cleft Lip Day. Many of you have heard this word, many of you may not have heard this phrase. So we will learn from the master himself, a man who has dedicated his life for cleft lip and cleft palate for more than 20 years. 20 years, guys. I have seen him in close quarters. He's done extraordinary work, he and his team, and they continue to change people's lives, not just patients' lives, but the families' lives. So help me introduce Dr. Krishnamurthy. Sir, welcome to our show.
Thank you, Sharon. Thank you very much for having me. It's an honor.
It's our pleasure. Sir, we have seen, when a baby is born, 2 hands, 10 fingers, good brain, a good heart, everything looks fine, baby is crying, and suddenly we see a slit here. And then the panic happens. So what is that? Can you just start with that? Let's get into the thing head on. What is the slit in the lip called?
So this is what we call a cleft lip. And if I have to explain it very simply, it's just a difference. As compared to what you would see in other people, this is a difference, right? For some reasons, the lip is not completely formed.
Mm-hmm.
And also inside the mouth, the same thing could happen. There's something called as the palate,
Okay.
which is like
inside here.
Which is like the roof of the mouth. It's the roof of the mouth and the floor of the nose. In other words, it divides the mouth from the nose. It's like a wall.
It separates it.
And this can remain open so that now we have a communication between the mouth and the nose.
Whoa, that means food can go from here to there.
Food can go.
My
The mother
goodness.
starts feeding milk. This is sometimes how people recognize it after birth, that when the mother tries to feed breast milk, it starts coming out of the nose.
I see.
Yeah.
So they see this, but they don't know something is going on inside.
Yeah, sometimes you
Got it.
Sometimes you can have a cleft of the lip where there is a opening, or it's not completely formed, and also a cleft of the palate. But sometimes you might see only the cleft palate, which means the lip is fully formed.
Okay.
And these are the ones that are missed. Even today, sometimes we see parents coming in at 1 year or 1.5 years.
Really?
Yes, it's been missed by our professionals at birth. And then
the palate without the lip.
when it is just the cleft palate, occasionally. And then baby is not growing well because she's not able to feed well. And then somehow it gets discovered by somebody and they come in, or when they come to us, we see that. So yes, that's a problem.
So I'm just thinking, imagine the child is born. It is such a joyous time for the family, for the mother, from the father and everybody else. And they suddenly see this deformity. You have seen thousands of such parents, grandparents, other relatives. What is the commonest 4-5 things that goes to their mind? What do they come and tell you? Is it a curse? Is it this? Is it? I mean, how do they look at it? How do they reconcile to this whole process?
The most common emotion is shock, obviously. As you mentioned, this is one of the most joyous occasion in any family, not just for the parents,
Exactly.
but the whole family. They're expecting
Yes.
a new addition and you expect it to be normal, and then you find something which you were not prepared for, you were not anticipating. It's shock, and obviously the grief or the sorrow, and then the fear as to what to do next.
What do you mean by fear? What to do next means what?
Because
Can you elaborate?
since they have never heard of it, most people, they've never seen one child like this. They don't know what will be the future for this child. Will she be able to grow up like this? Will she be normal? Will she be accepted by the society? So that leads me to another emotion, which is rejection. That
Oh, you
is
mean
terrible.
the family rejects?
Yeah.
You have seen that happening?
Yes.
You mean they abandoned the baby?
So sometimes the husband abandons the wife.
Good
That's
grief.
terrible. So he says, you can come back if you want. This is one thing that I've heard few times with my patients, that when they come to you, they come with the grandparent.
Okay.
And then I find out who is the father, who is the mother. Obviously, you want to know because you want to
Correct.
talk to them.
Correct.
And they say, father has said, I don't want this child. And there are a couple of instances where I said, I don't mind you come back home, but I don't want this kid.
What?
And there is a slightly different version also where the father says, if this child becomes normal, then you can come back home. So
Okay.
it's never that a family completely rejects. I think there's virtually no instance that I know where a mother has rejected.
I mean, that's why she's called
That's
the mother.
not, yes. But yes, father-in-law, husband, and so on, it has happened. And that might come in later, but that's the most powerful disincentive for a healthy family, It's terrible.
So they're now thinking what to do next. How
Yeah.
do we handle this?
Yeah.
So it comes back. First of all, you kept saying that father, mother. Is it the mother's fault that this cleft has happened? I mean, like I said, for example, there's a common misconception that if the girl baby happens, it's the mother's fault because everybody wants a boy baby. I've never understood this logic. And everywhere I tell them, I'm saying this on this channel also, is that the girl is XX and the boy is XY chromosome and the mother is XX. So if the baby has to become a boy, the father has to give his Y. And if the baby becomes a girl, it is 100% the father's fault and not the girl's fault or the mother's fault. First big message I want you to take out from this channel, not the mother's fault. And Dr. Krishnamurthy is again saying it's not the mother's fault. It's not even the father's fault. So where is the fault? Is it like a neurotubal defects? Is it a folic acid deficiency, or is it some deficiency in the diet, or where does the truth lie?
Before we go to that, can I go back to this fault business?
Sure.
So I have an instance. I came to know, I've been treating this child for a number of years, but I came to know the whole story yesterday in my clinic.
Huh.
And this one is a very professional woman
Okay.
who works in one big central government agency.
Okay.
So she got this first child. She had cleft lip. The in-laws and the husband were not happy, but she got treated. Now she's in 10th standard, this kid. And then they were hoping that the second child will be a male, like you said. Didn't want the female baby, and cleft was unnerving. And the second baby was also a girl, and this man divorced her.
What?
Yes. And not only that, he's been harassing her all these years.
Crazy.
So
I mean, brain damage.
you gave this message. It's unfortunately we live in such a misogynistic,
Don't you think so?
patriarchal system.
I agree.
Absolutely.
It's such a sick thing situation
Yes.
for no fault of hers.
Absolutely.
So they have to get the message. It's
Yes.
crazy. My goodness. And they're educated people.
Right. Yeah.
So we can't even call them educated. They're literate. The difference between education, literacy is you have got a degree,
He's,
but educated when you have common sense upstairs.
he's
Akal.
dodging the court. She's not paying for the children's. She's not asking for maintenance. She's just asking for, what is their right, the children. They're two. And then now I hear there is a non-bailable warrant against him.
I think so. You should be put inside. I think so. He should be put inside and turned upside down, shaken up, and
tell you.
whatever it. Huh? Because he should be. Some of these people should be made a role model,
Yes.
so the rest of them have that fear.
Yeah.
Because you can't abandon this. It's so unfair at the end for no fault of anybody at the end of the
Absolutely.
day.
So coming to that cause now that you asked about whose fault it is, it's nobody's fault. In nature, like we know, Sharon, evolution happens, and that happens through a spontaneous process called as mutations.
Correct.
So somebody becomes taller, somebody becomes stronger over 100,000 years, somebody's jaws get smaller, somebody becomes darker, and so on. So
Correct.
every single change, the reason why the life has survived on this planet is because of mutation.
True.
But it's not always for the good,
Correct.
Sometimes you get mutations in the genes. Basically, it's a change in the way a gene is programmed, can turn out to be counterproductive, harmful, if you want to put it that way. Now, so these are mutations that are taking place in the genes. It could be father's gene, mother's gene, both of them. It might have been handed over from a grandfather or a grandmother from whichever side of the family. So there is a lot of work going on that, but it's still not very conclusive because they've isolated more than 25 or 30 genes which may be responsible in different people.
Oh.
Unlike your sickle cell anemia, where there's one single gene.
I was just going to say that.
So but work is going on, but we know that genetic mutations are responsible for it, and therefore there is no point blaming anybody. We also know that sometimes these mutations are driven by external agents, like, for example, there is a drug you would be familiar with as a neurosurgeon. Ladies during the pregnancy, if they're taking phenitoin sodium, for example.
Oh, phenitoin causes cleft lip.
Phenitoin is known factor for
defect. I see. Oh, I didn't know that.
Yeah, but we hardly ever see anybody on phenitoin nowadays.
That's true. We don't use at all.
Yeah, so but that was a known causative factor. And also, you talked about nutritional deficiencies, particularly folic acid. We know that periconceptual folic acid has prevented huge number of neural tube defects, but for cleft lip and palate, we still don't have a strong evidence. There are people who also believe that it may be the problem in the way which you might have enough folic acid, but its utilization is not done. The metabolism of folic acid may be at fault even with normal levels. So work is still on. Therefore, this is a very, very common question. Every single parent asks me,
I'm asking on
why
behalf
did
of
this
them.
happen?
Yes.
Whose fault it is? Always. And
always. So this is so what I've asked you the right question.
100% of the parents will ask this question because somebody may want to blame somebody else. Somebody may want to really know what it is. Somebody may be worried about what will happen when they have another child. This is the thing that we will address later.
Right.
Yeah.
So I remember, since you said that blame, you made a statement when we were chatting offline. Everybody wants a perfect child. This is the statement.
Yeah.
Why did you make that statement?
Yeah. So what tends to happen nowadays, now you were talking about a situation where at birth, the parents find out that this child is born with a big difference, which is shocking. But that is not always the case today. Because of what technology is, all pregnant women undergo what is known as ultrasound scan throughout the pregnancy to find out the health of the baby, how it is growing, how much it measures, and so on and so forth. And at one point in time in the second trimester, they also undergo what is known as an anomaly scan.
So anomaly is if they have any defects in the body which they can perceive, limbs or anything, face, head, whatever, they can see inside the child's head also, and and inside the heart. So that's what sir is saying.
So you can see what is wrong with any part of the body to great extent, and there are specialists today who are doing this work, and when they do this between 17...
So what are these specialists called?
They're called fetal medicine specialists. They could be radiologists, they could be obstetricians who trained. And when they do this scan, many times they will pick up this cleft lip and palate.
How early in pregnancy can you pick this up?
Right. So
earliest.
The ones that I see in my practice, it usually happens at 17 to 20 weeks.
17 to 20.
But
that's
I'm told
second trimester.
Yes. But I'm told that it can be earlier. But in my practice, I don't remember anyone coming earlier than that.
Earlier than that at all. And you haven't heard it among the other colleagues also?
No.
That it's so before I go further into fetal medicine, So one of the previous statements you made was, we don't know whose fault it is, we don't know whose genes it is,
Yeah.
we don't know where the mutation is, we don't know what it is, we don't know what's causing it, there are too many of them. Which means what I'm hearing, in spite of all that you guys have done and the world has done, we are no wiser, not much wiser than what we were. And am I also right in saying that means it doesn't matter whether you're rich or poor, Caucasian or African or Indian or American, it's the same generally all over the world. Is the struggle the same? Are all countries in the world seeing this, or is it more a lower socio-economic problem?
Yeah. So there is a misconception
Hmm.
that it occurs only in the lower
Yes,
socioeconomic
yes.
families. That's not true.
Okay.
It's not true. You will see it in all classes of people.
Wow.
Uh,
So it's a
all over the
democratic
world.
problem.
Yes, all over the world. Sometimes the incidence is different racially. For example, the African population has a slightly lower incidence than the Caucasians, and the Chinese race has slightly higher. But it happens everywhere. And because we see in this country more people coming from lower socioeconomic background, because they constitute a majority of our population rather than uh, only them getting it. We see them in all classes.
All of us.
Right.
So it's a democratic problem. You have you don't have no idea how to figure it out, which means there's no vaccine for it. You can't predict whether the second child is going to have it, and it's like a lottery at the end of the day. And how common is it for the second child also to have this? How many have you seen?
Yes, quite a few. It has been also statistically been derived at the risk for the second or the third child having a cleft increases by a few percentage points, 2 to 3%. It's not a given that you will have one more in the family.
How common is a cleft lip or a palate to be associated with other congenital anomalies like a hole in the heart or some brain problem? Are they all? Is it a harbinger of many more things, manufacturing defects as we call it, or how common is
Yes.
that?
Yes, unfortunately, yes.
Oh, it's
Because,
yes.
yes,
Okay.
because you remember uh, in the first trimester of pregnancy, which means the first 12 week of pregnancy, starting with one single cell, the organs and the systems are being formed.
Correct.
In 12 weeks, you have a small
Small
human
baby.
being.
Yeah.
In that 12-week period, the heart is forming, the lips are forming, the limbs are forming. And so, if there is an insult which is causing this, that same insult or a problem in a genetic program could affect the formation, structure, and function of another organ.
So it's common for them to
Yes.
see more than one.
Well, let's not say it's common, but it's frequent. Okay, so you might some associations are more common than the other. For example, a number of patients who have a cleft lip or palate might also have a hole in the heart. There are a number of defects that can occur in the heart, and that's common. Some of them have problems with their kidneys or their ureters, sometimes with their limbs, sometimes with their eyes, sometimes with their brain, as you very well know. So, yes, the association can be explained because the problem is happening at the same time, and therefore it becomes very important. This is a visible defect. When the baby is born, they can see it. But if you have a hole in the heart or something missing in your brain, that may manifest much later as a bigger problem. So when you see a problem like this, a birth difference, you must make a thorough check to make sure that we are not missing anything, because it may not be obvious. We may need to do tests. For example, if you want to make sure the heart's all right, they do a simple investigation called the echocardiogram, and the echo always picks up these defects that may be there.
So I think it's very important for the audience to know that it's also important to pick up these defects, because lest they come for surgery, you do not realize, and then you give anesthesia, and then you can have a crisis on table because they might have a concurrent silent problem that could have been missed, and the anesthesia can make it disastrous at the end of the day. So two things are coming to me from as you're talking. One is the fact that this can be associated with other birth defects, as what you call, and they all can be picked up antenatally. That means this fetal medicine is becoming not only an important specialty but a critical specialty.
Absolutely.
So can you give our audience an elaboration of how does the fetal medicine work? How can they miss something? And what do you do after that? And what's the counseling process and things like that?
Yeah. So there are two parts to it, where it has been picked up and where it has been missed. We'll take them separately.
Sure.
So basically, as I said, in the second trimester, that is fourth or fifth month of your pregnancy, 17 weeks or 20th week, when they do a routine antenatal scan, they're checking for every organ, the heart, the lungs, the kidneys, and the face and the mouth and the brain, and then they pick up these problems. And then obviously, the very fact that this is being done to pick up a problem, then they sit with them and explain to them, look here, everything is all right, but your baby will have a cleft of the lip or palate, and that may be the first time. So,
You can pick up a palate also?
yes,
Oh, okay.
particularly when it's associated with the lip.
Okay.
But when it's an isolated palate, like I told you, palate alone,
can miss it.
it is missed. Remember, this ultrasonography is a technician dependent. You and I know that the amount of diagnosis, the details that you can make out is mostly dependent on how good you are at reading those things.
Correct,
and
correct.
it can be missed as well. And when it is an isolated palate, it is missed more times even from the experts. They may not. Today, the technology is developing leaps and bounds, and it might become a thing of the past, missing this. But at the current
Right,
state,
but the
some are
risk is
missed.
still there.
Yeah.
Well, it is skill dependent and more than the machine dependent.
Yes. When this diagnosis is made, the first person to break the news is your fetal medicine specialist. So, two things can happen here. One situation where the fetal medicine specialist says, look here, this is the problem. Do not worry about this. There are people who will take care of it. I will send you to this person. Go and talk to her or him, and they'll tell you what to expect, what to do, etc., etc. And there is a second set of advice that you will get saying, look here, we were talking about the perfect baby, right? So Sharan, and that's what the fetal medicine specialist also wants to give his patient. So he says, look here, your child's going to have a lot of problems. She'll not be accepted in the society. This will happen, that will happen. You have a chance, if you want to now, not to continue with this pregnancy.
There are people saying that?
Yes.
Even today?
I go back to another story.
Yes.
I was in one of their conferences about 10, 12 years ago, and one of these guys had asked me to come and talk about how do we manage cleft lip and palate. And at the end of the talk, at least two people came to me and said...
Two doctors?
Yes, the fetal medicine specialists were in the audience.
Fetal medicine specialists?
Yes, I went to their conference.
Oh, got it.
Yeah,
Okay,
so it was
I
the Karnataka State Fetal Medicine Congress.
Got it.
And then they came to me and they said, Doctor, we did not know these can be treated as well as you're showing here.
What?
Yes.
Which means, Dr. Krishnamurthy, this podcast becomes that much more important because it's not just for the public, it's even for the doctors to know that, listen, it's not a written off case, it's not a hopeless case, because the first person who gives that empowering or disempowering conversation is what sits in their people's mind at the end of the day, and that psychologically can kill the family and everything else. So there's still people saying that. It's amazing what you said.
Can I tell you another story?
Of course.
This also goes back a few years ago. There's this two well-qualified couple earning good money in a financial sector, etc. come in to my outpatient one day and said, we have come here for a second opinion. And I asked, what's...
Antenatally?
Yeah.
She's pregnant?
Yes.
Okay.
Pregnant, diagnosed with cleft lip and palate, and it has been and they've gone to one of the specialists treating this disorder, and he has told them the same thing. Your child is going to have problems in school to speak. Are you really interested in carrying this? If I would advise you, and so they had come asking for a second opinion. So this problem is a little more deeper than what we think, Sharan.
I mean, I can't say worried. I'm quite stunned at the fact that in this age and this era of internet, social media, where people are not sitting in one corner of the world, you have access to everything, 5G phone. And if they don't have access to this confidence building information, which is not rocket science at the end of the day, truthfully, and they don't know how to find people like you who can do this, you and your team, it is such a tragedy. How can you kill a life? It is such a tragedy. So have you really known people who have terminated the pregnancy in the second trimester?
Yes.
Yes?
So this patient who came to me for second opinion.
They went ahead?
Yeah. So I have a support group of parents
Mhm.
whose children we have treated,
Very good.
and I give their phone numbers.
Correct. That's the best.
Yeah. So this guy, one of these guys is used to work for Infosys, and then he works with us now. He's floated as trust called Chirantana, and he helps us identify patients and logistics
Very
and so
nice.
on using his
A
own
father
money.
of a
Yes.
patient,
Yeah.
child.
And the son is doing his post graduation in the US now.
Wow.
Yeah.
Amazing.
Yeah.
Amazing.
And so I give his number. He's one of the guys. His wife is another one. So the consultation got over, and this guy calls me. My friend calls me, the patient's father, the old patient's father. He's agitated. He says, Dr. Krishnamurthy, they want to terminate. Should I report them to the police? I said, don't do anything like that. Come on.
I was thinking the same as you were talking. I said, this is like murder at the end of the day.
Yeah. You know, I'll give another statistic to tell you how foolish it is to do it. You are a neurosurgeon and you
Yes.
see horrendous road traffic accidents day in and
Of
day
course,
out, and
of
you know the
course.
statistics.
Of course.
Tens of thousands of people will have their face disfigured as a result of an accident.
If they survive.
Yeah. Are you going to then not treat them? It's the same, right?
What a question you ask. Actually, it's very true what you're saying. Absolutely. It may be simpler than that.
Yes.
Because I have seen so many. See, the thing here is we have patients. We work on the same floor at the hospital, so I see his patients every day in the lift, outside, moving around, different sizes, different ages. So I see them before. I see some of them, immediately after surgery, subsequently, and I can see some of them you can't even make out that something is happening. So in this era of 2026, if people who are educated like this are still even thinking, forget about doing. Doing is, much worse than that, but even thinking that this child is, should be killed, I mean, it's unacceptable, unpardonable. Any unwords we have to use, I think we have to use that. It's crazy. So we have to drive this point home that, they can have a learning defect that they will never make out, which is much worse than this. And you are telling people who have gone up to become the best of the best. So now, so uh, so you are saying that the fetal medicine. So how many times these anomalies can prove positive clefts, the lip or palate, come to you antenatally when the mother is still pregnant, seeking second opening? Is that a norm right now? Is that expected right now, or it's just a rare thing?
It's exceptional.
Really?
Yeah. So
Really?
Yeah. There may be this. Now I'm guessing there may be two reasons. One is that a majority of these might not have had proper scans at all. Okay.
So which means they have missed on the scan.
No, they did not have scans.
Oh, okay. Either
Yeah.
they didn't have the scan or they missed it on the
It
scan.
was
Whatever.
missed on
Okay.
the scans. And sometimes parents have been upset that this ultrasonologist did not tell them the diagnosis. I would not know that whether that's a fact.
But when the report is written and they have not told, they should give it on the report.
Yeah. This is what they think. There's no way for me to know that because this happened 6 months later. This was a patient from Tumkur, I very clearly remember, very agitated. He asked me, Doctor, they would have known it, right? Why they didn't tell me? It's difficult for me to answer because they might have missed it. Whether somebody would intentionally not tell, it's very unlikely, I think, but it's a possibility. So, and then so many of them might not have access to that. Also, this is not so
Access
easy.
to what? To a scan.
Yeah. I don't know the statistics, but I'm sure we treat a lot of patients from very rural, very distant, far-flung areas. We go out and seek them. And many of them, we find out that they have not had a scan, period.
I mean, I'm just thinking as you're saying,
Mm.
is it because they don't have access to the scan,
I think so.
or they don't have an awareness that the scan is
I
required?
think it is access to the scan and probably the awareness as well. But coming back to how many people are coming, even when they know, there is, as of now, not a system where it is clearly, you see, these are the fetal medicine specialists who are diagnosing them. Unless they know where to send, these people. But however, this is being addressed. We have not come to this point still.
I know.
do
we're
all
going to
my
come,
work.
yes, yeah.
I do all my work with an organization called Smile Train, which is a New York-based NGO, which over the years has treated millions of children in 50 or more low and middle income countries, and they provide comprehensive. All our work is possible because of the support that this organization provides. Now, one of the initiatives they have taken is to work with the Association of Obstetricians of India, called FOGSI. So now we are training the obstetricians or in the fetal medicine specialists how to diagnose and how to counsel them, where to send them.
I'm glad that you're doing that.
Yeah.
So, just to sort of summarize, you're saying now that either first on why people are not coming to you antenatally is because either the anomaly scan has not been done,
Yeah.
or it has got missed because the right
Yeah.
kind didn't do. And also, those people are so upset or whatever it is, they don't come antenatally
Yeah.
for whatever reason. So, the first next message we're giving is, I hope this reaches every person through this channel and beyond, is that every person should have an anomaly scan.
Absolutely.
And I think that is, I mean, it's like the right to living or right to education or right to information. It's a right to whatever, you should call that. That's the first thing. Second thing is, you're reaching out to the fetal medicine people because they're the right kind of people next who see it on the image. Then they have to decide what is to be done.
Right.
And they should not only be counseled how it should be done, they should also know whom to send the child to, or the parents, not tell the parents to, so that the appropriate mindset, information is all set up. So you are saying, since you did mention Smile Train, I'll come back to that in a while, is you are saying now you are one of the few people who got a whole ecosystem in place to address this from antenatal all the way to what's happening. So you as Dr. Krishnamurthy and team, we'll come to where you are operating and all that in a moment. So you have that access to that, and we are hoping there are more Dr. Krishnamurthys going to come up and do this, and I'm quite sure that's one of the missions that you're working on.
Yes.
We're going to come there. So I think maybe we should finish that before we come back to the technical aspects. So tell us, let's start from the beginning on that.
Right.
What's your background?
My background?
Are you a medical doctor?
Yes. So I'm a dentist and a medical doctor.
Oh, you are both?
Yeah. So it's a rare combination in this country. We only a few of us.
That's right. I forgot that.
Yeah. So I was a dentist first, and then also a medical doctor, and then trained in facial surgery.
Got it. So, okay. So you did all of that, and then you could have done 100 other things, which I know, like, oral cancer, there's that. But you chose to do, you are like an evangelist right now.
You can say that.
Yeah, I think so, because the moment I entered Jain Hospital 2013, Krishnamurthy, so much. I said, who's this guy? I want to see this guy. I don't know what is he. I mean, you are like that guy who was all over the place doing all sorts of stuff. So, and I'm not surprised. I've seen the impact of the results that you're doing. So what made you to dedicate your life to this problem, which is not glamorous at the end of it? Let me be, it's not like, something that you go and thump your chest in the field and do. What made you get there?
Right. It's mostly opportunities and chance. In life, they say a lot of things are for you to be at the right place at the right time with the right person.
Yes.
So the first credit I would give to my boss, who was a passionate guy. Initially, he used to be my immediate superior staff member, and then later on, I worked with him as his number 2 for some years.
Where was this?
In Mangalore.
Mangalore.
I trained at Manipal and then worked in Mangalore, and so he was very passionate. And at that point of time, I was, like you said, this was not glamorous for me. I wanted to do cancer work and stuff like that.
Which is the most sexy one.
Yes, and then this thing happened where we had an opportunity to operate on hundreds of these patients. Yes, and that's once again the Smile Train story. Can I do that now? So what happened was, all these years, like you said, this was not glamorous. This was neglected. In a government hospital, the problem was of priorities. If they are talking about birth defects, they have to look at something that are life-threatening. They gave priority to save lives, and they did not have resources to take care of this kind of a problem. So,
Got it.
and then most of our people could not pay for this and afford treatment. So, if we go back 25 years ago in 2000, when somebody did a survey, they found out that only 25% of children being born with a cleft lip and palate hitherto were getting any treatment.
25%.
Only 25.
My goodness.
75% of all children born with a cleft lip and palate till that year were being completely untreated, and they lived and grew up like that.
I knew
if
when
they
I was
did
a
not
child,
die.
when I was a child, school, college, I knew some people, adults who had this.
Yes. And this 25% also had patchy treatment, not complete, not comprehensive. Okay. So at one point of time, at the turn of the century, there were hundreds of thousands of children, teenagers, adults who were roaming around with this. And then came this organization called Smile Train. Now, what they said was
Where
that
are they from?
they're from New York. So there's this Chinese American called Charles Wong who floated this organization out of New York. And
What is he? He's an oral surgeon?
No, he's a big businessman. He was in
What made him get into this?
that I don't know. But
Interesting.
whatever, he had that passion to do this, and more importantly, it was a model that he chose. There
Okay.
were a lot of charities that did this kind of work even before, and
Okay.
even now do it. But their model was fly in, stay in a hospital for a week, operate and fly back. Something what they call mission surgery or safari surgery. It served a purpose many years ago, but the problem with cleft is that you need continuum of care. You need to see them next week, you need to see them next month, you need to see them next year. And as we will discuss later, we will also have many other things to do as they grow up. And this was not possible with that model. So what Charles Wong said is that let's empower, find local partners and empower them.
Got it.
Allow them to build up. Let's support them, build the infrastructure.
So they build capacity rather than...
Yes. And
I think that's the only way, ground up.
yes.
I don't think there's any other way to decentralize and democratize this whole process unless you empower people locally who can, like you said, it's a journey that takes over many years.
I'll just give you one example.
Sure.
So when we started working at Bangalore here in 2005, the average age at which we did these surgeries was 11 years. So the average age of surgery. So you might do 5 of 1-year-old and 10 of 12 years old and 5 of 20 years old. Average was 11 years. And 10 years down the road, when by 2015, we were doing it at 1 year of age, at the normal age that they needed the surgery.
That's the right ideal recommendation.
Yes.
So you got onto the Smile Train bandwagon, is what we call.
Yes.
And right from day one, you were at the Bhagwan Mahavir Jain Hospital?
No, I worked in Mangalore in a dental school before that. And for 5 years, I worked with Smile Train there. And then in 2005, I came to Bangalore. I had an opportunity to set up a fresh unit from the scratch at Bhagwan Mahavir Jain Hospital.
I mean, we are colleagues at Bhagwan Mahavir Jain Hospital. We know the kind of stuff that they have been doing and they continue to do. But take us back and tell us, 2005 you came there?
That's right.
So did the trustees even know about cleft lip? How did they look at you? How did they really buy in? I just want to know, because there may be a lot of people like you who are trying to set up in other hospitals. They may get some, tips from you of how to approach management and how receptive a management should be and the kind of support they gave you.
That's right. There were two things in my favor already. One is I had colleagues who were ready to bring me in from inside the hospital.
Oh, okay.
And also, Bhagwan Mahavir Jain Hospital supported some of these mission surgeries till then. People used to come in, operate in that camp area for a few days and go away. So they knew what it was. And so now here we were coming in and saying, look here, we will provide this care round the clock, 365 and for unlimited period for everybody who can't afford, totally free of cost.
Oh, 100% free?
Yes.
Wow.
Everything. And then these are people who are looking for some project like that. And I must say that 21 years later, I made the right decision, because
I agree.
The kind of support that we have got, we still get, is truly amazing.
Incredible. No, we have to give it to the trustees and the management of Jain Hospital. No question about that fact. They've always, very interestingly looked at, the not down the beaten road, as what we say, the off-beaten stuff, and given us the space to think through it and, sort of give us the time to sort it out and build it up. I think there's no question about that fact. So now you land up bringing in Smile Train to BMJH. BN Bhagavan Mahavijayan Hospital is in Vasantnagar in Bangalore in India. So those who are looking from other towns, this is where you are. Dr. Krishnamurthy operates there. I also operate there. So now you brought in Smile Train, but then somewhere I'm not sure pre-COVID that leadership thing happened, or was it
Yeah.
so what you elevated your department to something called a cleft leadership center or something
Yeah.
like. So what is that? How where does that in the pecking order? Where does that go?
This is can I make it into a little longer story?
Sure,
Yeah. So
absolutely,
like I
absolutely.
said, we started in 2005. All we were concerned was in doing surgeries. Remember, we had a 50-year-old Aji who was also keen to get a cleft lip operated. I'm
I
telling you.
appreciate that.
Yes,
Yeah.
they came in. And so
And so there's no restriction. You can even do it later. Is there any
yes, you
challenges?
can do it. You may not get the same results for speech, etc. We
Got
will
it.
discuss that later, but you can still eliminate the visible defect,
Got it.
make life more
Cosmetic.
comfortable.
Cosmetics.
Also, oral hygiene can be better because no communication to the nose anymore, things dripping in and so on. So yes, so we were interested only in surgery, and everybody's interested in trying to clear this backlog so as to start getting children at the right age. And so we concentrated, everybody did, on surgeries. But these children need so many other things. They need speech assessment therapy. They need orthodontic treatment, which means their teeth and jaw may be in a crooked position. That needs to be aligned, because once they grow up, they may not look as good as they were when we did the surgery. They have serious psychological problems. This is what we were referring to when, I said that people were discouraging parents. Oh, why? Because sometimes children may tease them for their appearance and so on. So they need
Which
to be.
means the school should be also sensitized to
Absolutely.
and the
Children.
teachers,
Yes.
children, everybody. Yeah.
So all these are part of the package. We need to see them from the time the diagnosis is done ultrasound wise, the parents, till they grow up. But we did only surgeries. And then there was this urge that even though this is just a charity work, let us not take it lightly. Let's see whether we can also provide care at the same level as somebody who can afford, somebody who comes from a so-called first world country gets. So we pushed for speech therapy. Initially, we worked with a speech therapy school, and then we had our own speech therapist. We used to get orthodontists, kind-hearted people who were very good in the city, who would come and spend a day with us. But that was not complete care, continuous care. So in 2012, we got an orthodontist who was full-time. So we were building up capacity, and Smile Train also had management thinking now that we should support comprehensive care. Otherwise, we are doing a job not so well. So these things merged together, and we started building capacity. So
that's why.
At one point of time, now Smile Train decided that let's showcase some of our better places where full care is provided. Let's designate them as Cleft Leadership Center.
So hold on before you go there. So you said what you said from 2005. You started building it up. Initially, you were only clearing the backlog. Then you realized a speech therapist. Then you realized a psychologist. You're an orthodontist. You did all the pieces of the jigsaw puzzle. Was it all done because you, as Dr. Krishnamurthy, was interested to fix one by one problem, or was it the Smile Train already had a plan in place, or were you putting your own puzzle together in a way that the situation demanded on the ground?
I think it's a bit of both.
A bit of both.
Yeah. So it was always a problem. You see, for us, it was along with me when I started the unit. This is another thing I must tell. We were two to start off with.
Oh, who is that with you?
Dr. Preetam Shetty.
Preetam was there with you from day one.
Yeah.
Huh?
Today,
Oh,
he's directs the program, and I
know.
sit back and relax. So Preetam was there with me from day one, and we were just two surgeons, nobody else, no trainees, no other specialities, and we would operate, and then they would come back, and then the child's not speaking well. It leaves a hole in your heart.
Job or half-finished job.
Yeah, you think, what have I done now? So
same feeling I had as a neurosurgeon. That's why I started
without rehab. Yeah, yes. I know. So you start thinking, man, am I doing good or bad? And
very true. Very true. Very true.
And at the same time, Smile Train also, remember
And you
they
can
were
say, then Kelsa Agoto, you go somewhere else, you can
yes.
bump them, kick the
Iste
can
naan
down the road.
iste matter. I
Huh.
can do only so
Yeah,
much.
yeah.
Thank
I
you
mean,
very much.
yeah. A lot of times
Yes,
that happens.
yes, it happens even today.
Uh,
So, but at the same time, Smile Train also was now growing. They were creating more funds. One of the problems they had was they said to a donor, it's very easy to uh, gain their empathy by showing a picture of pre and post surgery. You know, any donor's heart melts with
Correct.
that. But to make them understand that this guy can't speech or the joys, it's difficult. So they also had
Ask
their
us, because that's why nobody donates to neuroscience, because
yes,
nobody
because you
understands
can't
us.
show the before and after
Yeah,
pictures. You know?
absolutely, of course.
Yeah, so they had this problem, and therefore it took them some time to be able to build up. So, but there was always support from their side. Yeah, so it, like I said, you know, you have to be in the right place at the right time.
No, actually, also
No
you are
single
the right
person
person.
can give credit.
Yeah, see, but Krishnamurthy, let's not give all the credit to somebody else. See, I'm quite sure, like you, there must have been 10 other people in the program in that Mangalore place, exposed to Smile Train, exposed to Cleft Lip. There must have been more than 10 people, 10, 15, 20, not just in Mangalore, in 10 other locations in India.
Yeah,
But everybody didn't go down the path that you have gone. The truth is that, because I know about that, you know. So the fact that there were a group, a set of people like you who thought this is more than just a surgery, it has to go beyond that. I need my responsibility to put up a whole system in place. And I'm so glad you did that, because sometimes the gratification comes beyond the surgery.
absolutely.
Don't you think so?
Absolutely.
Yeah, I think the kick comes when the whole package is delivered, right, rather than only one aspect. So now tell us, how did that process and how did it end?
Yeah, so so at this point of time in 2019, I think Smile Train decided that they will start building capacity, making something into a referral training center. They work in 57 countries.
Ooh.
Yeah, and thousands of hospitals. So they chose 5 or 6 places, one in Brazil, one in India, one in Vietnam, and so on, and said we will designate them as Cleft Leadership Center. Fortunately for us, just as COVID was breaking up or starting, we got this call saying we are going to designate you as a Cleft Leadership Center. Speak to your management.
Fantastic.
Your responsibilities will increase. Are you ready for the challenge?
Fantastic.
And
Fantastic.
of course, we were ready for this challenge, because what it meant was we could build more capacity. Since the time
And
we
end to
became,
end.
yes, since the time we became a leadership center, we have added on nutritionists, we have added a dentist, we've added the psychology, full-time clinical psychologist who takes care of our patients.
Excellent.
So we have a ENT support now.
Very
So,
nice.
so when children have cleft lip and palate, sometimes they can have problems with their ear, hearing, and they can get chronic infections there. And this might require treatment over the years. And you can't neglect that, because you might have repaired the lip and palate, like you're saying, but you may become hard of hearing in few years. So we were trying to find an end-to-end solution
Like a one-stop shop.
under one roof. So ENT was added on. So it has allowed us to now complete from the time of antenatal counseling till they finish and they're ready to fly off for their jobs or their colleges. We take care of them. That was important.
So you're the only cleft leadership in India today?
Yeah.
Huh?
They are hoping to add some more soon.
Whoa, I didn't know that.
But for the last 6 years, we have been, there are only 2 of them left in the world, one in Brazil and one here. But looking at the way
globally you're only 2?
Yeah.
Oh,
But looking at the way it is developed, I'm told that they're going to add few more in India, because India is a massive place.
I agree.
So
definitely
so
we at least
we were
10,
like
20 more Dr. Krishnamurthy.
we were like an experiment, and they are now going to spread the thing more. We were also a training center. We also carry out research. So we started training. You have said this couple of times already, that you cannot just have one center of excellence. It has to spread around.
Yeah.
And we as teachers, we find that more important than anything else, because you can only do X number of. But if you train 10 people, it becomes X.
And especially if they're geographically distributed, then access to care becomes much better.
Right. So we.
So do you travel now to other locations to train people? What are you doing?
Sometimes, but more importantly, sometimes I do that, but that's not the main part.
Okay.
Main part is the fellowship program that we run.
Okay.
So in 2010, we were granted this status by the Rajiv Gandhi University of Health Sciences through the dental school that I work, which is Bangalore Institute of Dental Sciences, at Mahavir Jain Hospital to start a surgical fellowship in cleft lip and palate. And this is a program recognized by the Rajiv Gandhi University.
It's a 2-year program?
This is a 1-year program.
1-year program.
So we have trained more than 25 people now.
Excellent.
Out of these, at least more than half of them have gone to different parts of the country, starting from Muzaffarnagar in Bihar to Orissa, to Tanjavur, to Vapi, to Jodhpur, to Gwalior, to Indore, and so on. We have people who are trained with us, working, set up like ours, trying to build up, set up like ours,
copy
all over the country. And these are
nice.
And one of our trainees, you know him very well. One of my first fellows is Deepesh Rao.
Oh, I didn't know Deepesh was your fellow.
2011. So when he finished his post-graduation from Dharwad, he came and he did a year's fellowship. And so we have the gratification of,
I agree.
Seeing
Every
our own
teacher
boy
loves it.
grow up.
I agree.
And today, when
You're
I'm
doing a good
lazy
job,
to do
good
something,
surgeon.
I say, Deepesh, this case is yours.
Deepesh does a good job. I've seen him operating. He does a good job.
And I'm very proud to say that
Fantastic.
he's one of our trainees.
Fantastic.
And Preetham was my postgraduate resident as well.
Preetham is like your right hand at
Yes,
the end of the day.
Yes.
Yeah, I've seen. And that guy is also, Preetham is also very gung-ho about
Very
it.
energetic,
Yes.
excellent surgeon.
I agree.
So that's how you build a team.
Thanks, Preetham, for what you have done.
Not only at our place, but throughout. And also in 2015 or 16, there's an International Association for Oral and Maxillofacial Surgeons, a global organization which also helps train people.
Which is for which Dr. Sanjeev is the president?
He just finished his presidentship.
Okay. Yeah. Same organization.
So they run fellowship programs where they select candidates from deserving areas and provide the financial resources. They select centers. There are 2 centers for training cleft lip children, for training people to treat cleft lip children in India. We are one of them. So we have now...
You're getting international fellows also.
Yes. So right now, girl's working with us. She's from Nepal. She'll go back and set up her thing in somewhere in Nepal. We've had people from Iraq, from Israel, from Sudan, from Yemen, Nepal, Turkey. So we have not distinguished between different parts of the Middle East or whatever.
As doctors, our only job is to treat human beings at the end of the day. It makes no difference for us. And we want a willing student. At the end of the day,
Absolutely.
That's the most difficult to get.
Yeah.
You may have the greatest program, but if nobody shows up and does what you want them to do, the passion has to come in, because surgery lands up to be sometimes only 25% of the whole work. There's so much more happening, including the push and pull, getting people on board, making them understand. Some of them need brain surgery that you have to do just to get there.
Yes.
Yes. I can imagine. I think we should, through this medium, thank the Jain Hospital management, the trustees, and everybody else, past and present, for really being such a valuable support to you for what you have done. But for them, you could not have had a free hand to do what you're doing.
Absolutely.
And I can see the extraordinary work that you're doing. Fantastic. So congratulations again for the cleft leadership. So
thank you.
Before we get into the technical aspects, the last part of the cleft leadership is this Miss India connection.
Right.
Where does this Miss India, we just saw this video just now, but the Miss India connection here. So where does this Miss India fit into this cleft leadership?
So
what's that mystery?
If you remember, there's a parallel strand running in these stories, that is Smile Train. Okay.
Correct.
So we work so closely with Smile Train. We get all our resources from Smile Train. They are the ones whom we are accountable to. They also had an agreement with the organizers of the Miss India pageant that the winner becomes a brand ambassador for Smile Train during the time she is the queen.
Amazing.
And
that's a very nice gesture.
So they propagate. There's another video which I haven't sent you where the previous lady speaking to me for 30 minutes like this. That was done online during COVID.
Please share that. We can put that as a link.
So what they have done is that through the medium they have advocated. For example, Aishwarya Rai is one of our brand ambassadors of Smile Train for the whole country, not just for Mahavir Jain Hospital. So because of this connection, we have these people visiting in, advocating for our children, also finding out how their journeys are,
So this has been going on for how long? This Miss India business.
I think for more than 4-5 years. Yeah.
Are you saying thanks to these people that more visibility has come for this thing and more awareness? Is that
Absolutely.
helping?
Absolutely. So when we did, when Smile Train finished 500,000 surgeries in India,
What?
500,000. They finished 1 million now. Yeah.
Oh, 10 lakhs?
Yes. So
Over
because
what
we have
period of
more than
time?
100 hospitals in the country
Over
who
how
are
much period of time?
over a period of about 20 years.
20 years, 10 lakhs. Wow.
About 30 to 40,000 surgery every year
Every year?
throughout the country. We do
This-
about 600-700 of that, but there are so many places.
So you are telling me that apart from this Smile Train 100, there must be more centers doing cleft lip and lip. Because I knew
Yes.
Manipal Hospital also
Yes,
used to do at a point
yes.
of time.
There are other charities also.
Oh,
Yeah.
that's a serious number. That means it's not a small number of
No.
people. Ah.
No. Every year, 35,000 children are born with cleft lip or palate in this country.
35,000.
So it's roughly 1 in 700 births is a cleft lip or palate. And we have about 25 million children being born in a year. So it translates to like 35,000 children every year, newborns. And they need treatment from birth till that's 16 or 18, variable, obviously.
Got it. Not
So,
everybody. Yeah.
so you were talking about how contribution from these ladies has
Yes,
helped.
yes,
So
yes.
when we did this 500,000 surgery to commemorate that, they had an event, Smile Train. They called a lot of us partners, and Aishwarya Rai came in and spoke. And you should have seen the commotion from the press that day.
I can imagine.
Yes. So
I
yes,
can imagine.
they,
So that
they
it
give
gives you
some.
that,
Yes, they give
visibility.
that. Yeah, and it's very important. I think. Remember, they're
I
not
only
only.
remember when Manisha Chillar, somebody like that.
Yeah.
That's when we were on the floor together.
Yes.
Yeah, I'd also moved to the 6th floor
Yes,
and we were there.
That's right. So what happens is the objective here is twofold. One is that awareness about this difference, how it can be treated, how there is organization helping comes into play. Also, remember, these people are also fundraising.
That's right. I didn't
Yeah.
think about that.
Yeah.
So they raise funds also. So
Yes.
okay.
So when
Is that part of their mandate or is just that they do it as extra?
yes,
What is the mandate?
not the ambassadors,
No.
the organization,
Okay.
Yeah. the charity.
Correct, the charity.
So they are also getting this limelight so that they can also approach donors.
And there is a visibility that these are people
Yes.
doing some good
Yes.
work and things like that.
So
I'm
on the
quite
same,
sure because we have Dr. Vasanthi Anand who's doing the cochlear implant.
right.
It's the same way that she's doing a lot of free surgeries
Yes,
here,
yes.
thanks to the government of India
Yes,
support.
yes.
And again, thanks to the management of Jain Hospital support.
So one of
I
our
think
juniors, Lakshmi, is the one who does ENT for us.
that's right.
Yeah.
That's right. Yeah.
For all Smile
Small
Train
world.
patients. Yeah.
A small world.
She
within
comes
that.
once a week now, provides all the outpatient care, surgeries as well, tympanoplasties,
We share the
mastoid
OT. We
surgeries.
share the same OT.
Right.
She uses our microscope and all that.
Okay,
Yeah.
okay.
So that's
Oh,
how.
when she does the cochlear
Yeah,
implants.
the cochlear. Yeah. And then
Yeah.
Vasanthi and
I
Anand
met her
are
in
1
the
year junior
coffee
to us.
shop the other day.
Yeah. 1 year
After
junior
many
to us in Bangalore Medical College.
Okay.
So that's how it is.
So you're which batch, BMC?
Joined 86.
Oh.
1986.
I was 80 to 85 in GDC and
You, okay,
1980 to 85. And we shared the same hostel with
Correct.
BMC.
Yes,
so
yes.
we lived in the
I
BMC
was a
hostel.
day scholar. So
You were a day scholar. So we have done a lot of noisy things there at the BMC
I can
hostel.
imagine. I can imagine. We'll talk offline.
Yes.
So anyway, so now that you have set the large context, the social impact, the evangelist zeal with which you have worked and put this in place, the fact that you're the only cleft leadership in India, only 2 in the world, and that is something that we have to really hats off to you and your team. So now let's get into the hard stuff. How do you operate? How do you screen a child? What happens? Is there antenatal surgery being done? Not necessary. Sometimes in neurosurgery we try to do intrauterine surgery. It's not required in cleft lip, I think. It's not required. So now the child is brought to you, let us say, 2 months after their birth. So walk us through how does the whole process work? How do you evaluate so people understand and then they spread the word?
So very important things to say here. I'll start with the
Yes.
intrauterine surgery. People did try it on the goat or the sheep or whatever. But then it was found that you're taking so much of a risk for a simple thing like this, because remember, you have to do a C-section, pull out the baby, put it back. So I don't think
Not worth
it
it.
gained traction at all. So
Got
it's not going to happen.
God.
But
And not necessary also. It's not going to
absolutely
change
not
anything.
necessary. If the baby is going to die otherwise,
Correct.
intrauterine or immediately afterwards, I think those situations it may be useful. Now, we don't want to see them at 2 months. We want to see them right after birth. This is something
Oh,
I want to emphasize to every one of you, that if you see somebody who's got a cleft of the lip or palate, ask them to go straight away after birth to the nearest hospital like ours, which provides this care. The reason for this is twofold.
so how do they find? You made you made a very matter of fact statement. The truth is, how do they find somebody like you? I mean, if they ask somebody, is it easy to find?
Yeah,
Somebody guides them,
it's very easy to find.
or it's an online process?
Yes, no, it's very easy to find. So there are different ways of finding us. One is through other patients. This is how it works very, very well, though
The
it's
word
very
of mouth.
informal.
Mm.
Most of our patients today who are walking in are those who have been referred by somebody else who's been treated with this. That works very well. We also in the Smile Train have a helpline number. Maybe we could put it up
Sure,
on
why
the
not?
thing.
Yeah, yeah.
So there is a 1-800 helpline number,
Excellent.
24/7. So if
Excellent.
anybody anywhere in the country, need not be in Bangalore, sees a cleft and has listened to this, can just bring that number and they will tell you the nearest place where, and they will give their contact numbers.
So that is what you guys have to memorize from this podcast, is that the number it is showing up below. Call them up and they will guide you to the nearest good center that you can get going. Fantastic. So you answered the next question.
Yes. So now we have two concerns. We want to see them straight away after birth. So whenever we see these parents antenatally, those few which we see, I saw 2 of them last week, which never happens in a week. What we tell them is, wherever the delivery happens, moment the mother and baby are free to leave the hospital, they're in good shape, please come over to us.
Excellent.
Because there are 2 reasons here. One is feeding. Because remember, the baby has to be fed as soon as she's born. And if there is a cleft palate, if it's a lip, it's not a problem. If it's a cleft palate, breastfeeding is almost impossible. In some exceptional cases, clever mothers might learn it, but most of them cannot. And if they do not understand, the baby will not gain weight, failure to thrive with very serious consequences.
It can be disastrous.
Yes, it can be disastrous even to the life of the child.
I agree.
So therefore, we would like to...
Failure to thrive is...
Yes. We have seen people a kg less than birth weight at 6 weeks or 8 weeks. Simply
Really?
because the mother did not know. It not everyday affair, but we see them often.
Long enough.
Yes.
I mean,
So that's the important thing. We want to make sure that the mothers learned how to feed the baby. It's not difficult, but it's different. It's not spontaneous, like the baby latches onto the mother's breast. That's very simple. It's a natural process. Nobody need to teach. But here, we have to teach the mother and the baby how to take milk. We prefer expressed breast milk. This is one of the important message I would like to give, because if we can't breastfeed, the next best thing is to express it and give, because all the benefits of the breast milk.
How do you
You
give?
can use there are various options. You can
You
use...
teach all of that.
Yes. Yeah, we do. We have a nutritionist, remember, that's our first job. So we have specialized bottles without the baby sucking on it. Normal bottles that we use, baby has to suck like you suck on the breast, but these bottles don't need the baby to develop negative pressure and suck. There's specialized number of them available.
But do you give them some mechanical support there? Is there something like that?
I'll come to that.
Okay.
Or they can use a spoon or a palate also. It's not very expensive. We'll need to teach them how to do it. If they lie down and feed.
That's the most important.
Yeah. If they lie down and feed, it's not going to work. They have to keep the baby in a 45-degree angle and slowly feed. Remember, if they pour it in, half of it may go to the lungs.
Correct.
So you have to make sure that the pace that this
Child
is
can
what
die. Child can die because
this
of
is what we will teach.
Excellent.
And then we talked about nasoalveolar molding. Very, very important thing. The plate that you were talking about. This is, as far as we are concerned, revolutionized our results. This is something the orthodontists do in a baby 7 to 10 days of age. They will...
So they take a mold?
They will take a mold of the jaw, and then the jaws are widely separated in the cleft because there's a gap and the nose is badly deformed. Then they work on both the gums, the jaws and the nose over a period of 2 to 3 months and shape it more or less to become normal. So this is a pre-surgical before surgery molding. So it's called pre-surgical nasoalveolar molding. Simply before doing the surgery, we are molding particularly the nose, so that when we do the surgery, the resultant deformity will be very minimal. In other words, the results will be the best that we can.
And the recon also will be much lesser. Anything
Absolutely.
reconstructed will have its own
Yes,
limitations at the
yes,
end of the day.
yes.
I didn't realize that you're actually, that means they have to be constantly,
Yes. So they
putting
come
new
once in
molds.
15 days or 1 month.
Uh-huh.
So when they come, if they're antenatal, we even demonstrate that to them. But when they come in after birth, our orthodontist will take an impression. Today we have scanners, we don't have to do the old kind of thing. We have these scanning machines which will take the impression, and then we can do everything outside in the lab. So once these things are done, they wear it, and as the thing starts moving, they need to adjust it. So they keep coming initially.
So what material is this?
So this is made of acrylic, and then it's steel wires.
Oh, you have to fix it.
Yeah. So it's fixed to the
baby?
to the plate,
kit.
to the plate, not to the baby.
Ah,
So these
you
wires
just
are
insert it.
fixed to the plate.
But it's
Yeah,
inserted.
it's just
into
an
the
inserted
Ah,
plate
ah.
with some tapes on.
Okay.
And slowly, as it gradually improves in the shape, till we get the desired effect. So sometimes we wait till 4 months also to do the surgery.
So how early do you do this? That's
So
the next
if the child
automatic
doesn't
next
need, if
question.
it's a minimal defect, sometimes they can have a partial clefts. We can, we don't
But
need
you're
to
only
do,
talking lip, or you're talking
only
both?
talking lip. We need not do
Let's
molding.
let's talk lip now first,
Yeah.
then we'll go to palate. Yeah.
When we don't need to do molding, then we can operate when the child is 5 kgs.
Okay.
And usually they are 5
That's
kgs,
our
like
thumb rule
2.5
is
to
5 to 6 for even
Yes.
for the spina bifida.
Yes,
Same,
correct. Same
Same
thing.
logic.
Now, if you are doing a molding, we might wait beyond. If it's still improving the condition at 3 months, we will wait. So the orthodontist is the final arbiter. She says, look here, the nose is still improving. Let's wait for another 4
Perfect.
weeks.
Makes
So
sense.
it's a little bit of a subjective thing. Sometimes it goes up to 6 months. We can get, in lips, we have two kinds, unilateral and bilateral, which means it can be one side or it can be both sides. When we have both sides, the deformity is more severe because the middle portion is not restrained by the muscle, it grows forward, and then we need to reposition it. And the benefit that you'll get from this molding is tremendous, which is difficult to get only with surgery. So we wait till that is ready. So 4 to 6 months is what we would generally operate the lip if molding has been done. But from a safety point of view, at 3 months they are ready.
So that's the earliest is then 5 kgs, 3 months roughly. That's where you start thinking.
Yes.
If the child, everything else is ready,
Yes,
that
ready,
you
we can then
consider to go down that path. Got it. So then let's talk about screening the palate also before we go into surgery. So now suppose the child has a lip and a palate.
Yeah.
What changes in your strategy? Anything changes more?
So if cleft lip alone is there, mother can do breastfeeding. It's a huge difference.
Correct. Huge difference.
Yeah.
So the chance of nutrition problems are much lesser.
Much lesser. They grow well. They get all the benefits of that breastfeeding provides, which everybody knows.
Got it.
But when it is palate, it's virtually impossible. There may be some exceptions, but virtually impossible. So that's when we establish that feeding is possible. We oversee it. Regular follow-ups.
That's the most important.
We oversee for safety reasons.
I agree.
And then we need to make sure that the child's putting on adequate weight week on week, month on month. That is the major challenge if there is a cleft palate.
Got it.
Also, when they feed, if they don't do it properly, it can come out of the nose. So the other thing, this is not because of the cleft palate. Sometimes they also have reflux.
Ooh.
Yeah. Reflux means food goes into the stomach. After a while, part of it comes back up. When the child is sleeping, for example, and then it can trickle down into the lungs.
Because of?
So this is additional problem that they have.
It's not a congenital problem.
It is coming with the cleft palate. Yes, it's congenital. And because of this, sometimes they have recurrent infection of the chest. So they come with recurrent, what we call as LRTIs, which is pneumonia. This happens because when they're sleeping, it's not being aspirated from the mouth into the lungs, but from the stomach, it goes up.
Comes backwards and then goes into the lungs.
So this is something we need to keep an eye on because we are seeing them regularly.
Got it.
So the child is getting chest infection, is not putting on weight. We need to investigate, find out whether there's a reflux. We work very closely with pediatricians in this period. We have excellent support in I forgot to mention them in the team. They're very, very important. Two important components we haven't mentioned, the pediatrician and the anesthesiologist,
Right.
because they are very important cogs in the wheel.
Absolutely. I
So,
agree.
so then they might give them medical treatment. Sometimes if it is very mild, just drugs are required. They put them on these medication and the reflux goes away, baby starts thriving. But there are extreme situations where the reflux is very severe, it's not managed by medications, we may need to do a surgery.
Oh.
Just 10 days ago, we did a surgery, or our pediatric surgeon did a surgery for one of these conditions. They then make, this happens because the junction between the food pipe and the stomach, the esophagus and the stomach, is not in the right position. So they do a surgery to tighten the fundus, the fundoplication they call it.
Got it.
By that, they will prevent the reflux.
Got
So
it.
sometimes that is required. Otherwise, you are all worried about the cleft lip and palate. Child is getting repeated chest
And you think
infections.
it's coming from here, it's actually coming from there.
Yeah, and it's not thriving, and then life becomes hell, and it can be life-threatening too. I know of a child which came in congestive cardiac failure with repeated infections because he had very severe reflux. So the problems can be multifold, and
I can see
because
that.
we
And child, their reserve is also very,
very less,
yeah.
and because they come to us because they see the defect, if we don't keep an eye on
Correct.
the overall, what is the point in just closing that
I
hole?
agree.
Yeah.
My follow-up question to the LRT, the lung infection, is that if you see 10 children with lung infection,
Mm.
is it a 50-50 deal, aspiration from top, aspiration from the bottom? Is more common from here?
I think it's less common from.
Okay,
less
so it's
common.
more from there.
Yeah.
Okay, so I'm going to ask you a follow-up question to this. You
Yeah.
said they put that whatever mold for the
Yeah.
lift.
Mm.
Yeah, what do they do for the pellet?
So there is a plate inside. Part of that molding is a single
extension.
appliance. It goes all the way to the hard palate.
So
Feeding
whether the hard
becomes
palate
easier.
is normal or abnormal, this fits in the same
Yeah,
way.
mostly when it is there, the palate, that's when we are doing it. If it's hard palate is normal, they might just do the nose thing. There is a modified appliance. But usually this is done when there is a cleft in the hard palate. So it also helps in feeding.
Correct.
There are times,
that was the
yeah,
key.
there are times when we need it only till the lip surgery because we are molding and then we do. But parents come and say, can we continue to wear this because it helps us to feed? And then we say, yeah, go ahead.
Very nice. So we've got some contraptions to help. So, okay, now it's all the pre-surgical evaluations happen. The child has been prepared. The child's weight is 5 kilos. You know, the orthodontist has done whatever they have done. They said, I think we have done the best. The child is now ready for surgery. So what happens next?
Yeah, so we need to make sure the child is fit. This is, like you said, the reserves are low.
Correct.
Sometimes their hemoglobin, we find, to our surprise, is less than what we want. We normally look at 10 grams. Sometimes they might have had a chest infection, and doing anesthesia in the next few days is going to be risky. So we assess them. Once again, pediatrician works very closely with us. We do a pre-anesthetic evaluation with the anesthesiologist. He is the person who makes the child sleep, as you know, before a surgery. So these two people come in at this point. Once again, the pediatrician and the anesthesiologist, they assess the children. We do routine investigations to make sure everything is all right. Your red blood count, your white blood count, your platelets, that you don't have abnormal bleeding tendencies. So we make sure that the person's fit for surgery and then fix up a date for surgery.
Got it. Now you're operating through the mouth.
Mm-hmm.
So how do you put the anesthesia tube with the mouth? Is there a challenge for that?
Yeah,
or?
it is a challenge when we do the cleft palate once again, because when we need to do the cleft palate surgery, we need to have access to that area.
Correct,
So we have to open the mouth wide.
Correct.
And so we put in a contraption called the mouth gag in order to open the mouth wide. And this gag will go and press the tube that they have put inside the mouth into the trachea or the windpipe.
So the tube is behind the
Tube is below.
Okay, below.
It's
okay.
below the gag.
Got it,
And
got it.
sometimes it can compress it. So we are basically sharing the airway. Let's put it that way. The airway is very important for the anesthesiologist because they're keeping the baby sleeping as well as alive by things that are going through that tube that they put, which they call the endotracheal tube. And that goes through the mouth into the windpipe. And we are working inside the mouth. So we are using a shared airway. It can be risky. For example,
Yes, I was going to say
sometimes
that next.
the tube can come out.
Exactly.
So we have safety mechanisms, you know that, today we have monitors which will tell us at the immediate second that the tube is out and so on. But this is a challenge always, that we work closely.
Got it. So it's not a simple, straightforward
no.
surgery like an appendix. You
No.
come, you go.
No.
It has its own risks, and
Yes.
this can be life also at the
Yes.
end of the day.
Yes.
And you are saying, every location which does cleft lip cannot do high risk surgeries. You are one of the few places you can do an, ASA grade 3 and more and things like that. So which is very good. So high risk surgeries, these are the people at Bhagwan Mahavir Jain Hospital who are, I think, geared up to handle most of the risky things. So then you do a recon. So what do? You just, how do you fix the gap?
So we work with the available tissues around, both on the lip as well as the palate. So remember, the tissues are there, but they're in abnormal place, right? The most important component of the repair are the muscles. Today, everybody goes to the gym, and what you're doing is building your biceps and your triceps. And similarly, we have muscles for the lip and muscles for the palate. They're very small. They're not like your biceps, tiny muscles.
Child is also so small.
Yeah, but we need to make sure that they're reconnected and they function. That is the key to the repair, is muscle reconstruction. We find where the muscles are abnormally attached, both in the lip and the palate, and we bring it together. And on top of the muscle, we close the skin. Skin closure is also important because we don't want to leave scars. This is something very commonly in the Indian context. When there's a girl child, the parents will say, "Doctor, this is a girl, I have to get her married. Please make sure there are no scars." As if the boys need scars. We don't need scars too. So, but that's a common thing that happens in our thing, and we need to say that that's our aim. When we do surgery, not only that we have to do this reconstruction of the muscle, we also have to work carefully so that we don't leave very visible marks for the rest of their life. So that these are the two important components of the repair.
So when you're repairing the palate, how do you get the cartilage bar bone cover? You have to move something?
We don't cover the bone.
Oh, the molding is already... Okay, you don't cover the bone.
No, that stays as a gap. We only cover the skin. So skin on the mouth side, skin on the nose side. So what is called the oral mucosa and the nasal mucosa in the hard palate.
Got it.
At the back of the palate, there is a soft palate where the muscles are. There it is 3-layer closure. There's a skin on the mouth, there's skin on the nose. Sandwich between that is the muscle. Bone, we can't move it. So
you're saying the cleft palate extends to the soft palate also?
Yes. That's the problem area. Because the function...
I always thought it was only in the hard palate.
No.
Shit, I didn't realize
when
that.
it is in the palate, it starts from the back and comes forward. It invariably involves the soft palate, may or may not involve the hard palate.
Oh, really? Oh, I was so mistaken.
And the functional element is soft palate, because we haven't discussed this in great detail.
Do it now.
The most important thing that we hope to happen after a cleft palate repair is that the baby can speak normally as she grows up. Speech is critically important from a point of view of the cleft palate. A functioning palate is very, very important for normal speech to happen.
You should do a very good job on that, not just about closing the hole.
Yes.
You have to,
closing the hole may be a waste of time if the child cannot speak well. If as she grows up, they cannot understand.
And you would not even know that when you close it. The effect is going to be known so many years later.
Yes, this is the challenge.
So how would you know whether you have done I'm asking a very stupid question.
No, not at all.
The audience. How would you know that you've done a good job and the speech will be all right?
Yeah, so it's not possible to guarantee this. I always tell this to my parents. The only thing is sometimes we have indicators. For example, baby is well grown, the muscle bundles are nice and juicy. You get a good. You think this will work. The cleft is very, very narrow, so there was no tension at all on closure. So there are some indicators that tells us that it will work.
Some predictors are there.
Yeah, but it is not foolproof. Okay. So we wait.
You have to wait.
This is what they call the fourth dimension, the time. Yeah. And that's where follow-up. I mentioned the importance of follow-up, how continuity of care is required. So after we repair the cleft palate between 9 to 12 months, the lip at 4 to 6 months.
They
are two different surgeries.
Two different surgeries.
Usually.
So you do the lip early because lip is simpler,
because it's appearance
visible, but
thing,
yet it's simpler also, and then
palate little later when it grows up and is able to.
Okay, so what, 8 months to 1 year?
9 months to 1
year. And that weight has to be more different?
Yeah, so it has to be between 7 and 8 kgs. And today we look at the WHO has these growth charts, what are known as Z scores. We look at the length of the baby, the weight of the baby, and see whether it's within the normal band. Not strictly
The
1
normal-
point,
the- okay.
a normal band, plus or minus 2 standard deviations is what we look at, but it's about 7 to 8 kgs.
Got
So
it.
once this palate is repaired,
If the child comes in at 8-9 months without having repaired either of them, so you still stage the
no,
surgery?
then we won't stage it.
You will not
We'll
stage
do
the
it together.
You do it together.
Together.
So when
Yeah.
they're older, they're
Yeah,
better
if
than
they
7,
come
8,
in,
you can do
yeah,
it together.
It would be nice to operate everything together, but nobody wants to wait, you know.
So why don't you wait on the child to do?
Yeah.
On behalf of the audience, I'm
Yes,
asking you.
yes. So
Even the child comes early. Why not wait?
yeah, I would prefer to do the surgery.
What's the difference?
Once,
What's the benefit?
Yeah, I would prefer to do the surgery both together.
Ideally.
Unfortunately, I cannot do the cleft palate at 3 months. It's not safe. It's not allowed. We have guidelines. So the earliest we can do a cleft palate surgery is 9 months. The earliest we can do a combined procedure is 12 months.
So you got already clear guidelines.
Yeah, we have
Excellent.
guidelines. We are bound by that. Otherwise, funding will stop, for example. So at 12 months, if a child comes in, we will do both. Now the question, why not wait till 12
Yes,
months?
yes.
There is no harm in doing that. But invariably, no parents wants to see the child with an open cleft lip. You know, interestingly, it's anecdotal. At some point of time, they started what was called as neonatal surgery, not intrauterine. So they said, see, this is a blemish. Baby is born in the hospital. We will do on the 3rd or 4th day. When you go home, it's repaired. But they found there were a lot of safety concerns. It was, when they audited it in the UK and places like that, they said, this is not warranted. Please don't do it. But at the same time, we would like the mothers not to wait. Given a choice, very, very few people say, I'll wait till 1 year, you do both together. The advantage of doing both together is it's one instance of surgery.
Correct.
So,
One anesthesia.
Yeah, one anesthesia.
So let us say, suppose some parent chooses to wait. So there's no harm in waiting.
harm.
There's no harm.
For the palate, it is critical, not for the lip.
Palate anyway, you have to wait for 12
Yes,
months.
yes,
But
yes,
you can
correct.
wait and do both, except for the cosmetic effect.
Except for the cosmetic, there is
nothing else is going to happen.
Timing in cleft palate is important because I go back to speech. Longer we wait, more chances that the speech is going to be defective, because children start using purposeful words around the age of 12 to 13 months. So at that time, we want to have a structure intact.
Got it.
Yeah.
Got it. So I get that. So that's the next part. So I didn't know the soft palate part of it. That's a learning that I had just now. So you've repaired that, and then you start the speech therapy. So the speech therapy started how?
So what they do is they see the child even before she starts speaking. Some places see it before cleft palate repair. We do it afterwards. 1 month, at 1 month follow-up, we now refer the child to we call them speech and language pathologist or SLPs. But in common parlance, they're the speech therapist. They're much more than therapists. They understand speech and language. That's why speech language pathologist. And they will start talking to the parents at that time. They can't talk to the child at 1 year.
Correct.
They will tell them how speech will evolve, what they can do to stimulate the child to speak at home. They will also assess language development. If a child has to speak, she has to have a vocabulary. She has to understand. If a child is being exposed to Kannada, she will speak only Kannada. She won't be able to speak English. So they will also assess the language development. And then every 6 months to a year, they start calling them, assess speech. Sometimes the child may not be cooperative when she's 1.5 or 2 years. So they ask them to record a speech sample and send it. When they do that, you can assess what's the stage of development. So there is a constant hand-holding that happens from the speech and language pathologist till such time they're sure this child can speak normally. Some of them, in various samples of ours, 30 to 50% did not require any therapy. They spoke spontaneously, normally. But other, 50 to 30% require therapy, which means they're speaking now, but they're not able to pronounce some syllables. I'll give you an example. They can't say pa properly. They might say ka. So instead of saying papa, they might say kaka. And nobody knows what it is except the parents who think it's okay. They can understand. And therefore, they start therapy. And then there are about 10 to 15%, sometimes up to 20% of our patients require another surgery too.
Oh, what is
Because
that?
now in these patients, the palate is not functioning 100%, right? So it's short of its function. And therefore, we need to do another surgery to lengthen, make it better functioning. But that we will come to know only when they're 4 or 5 years of age. And that is the window for us to work on those children. So half of them don't require any further, just monitoring. Another 1/3 will require therapy, and another 15 to 20% need another surgery followed by therapy.
So how do you decide? Sorry to butt in. How do you decide who needs surgery? I mean, you have a
Yeah.
evidence-based way of
Yeah.
doing that, like a scan or something. Or what do you do?
Yeah, there are two ways. We have our friendly SLP. She will do what is called as a perception. What she hears. There is a standardized protocol, and with that they can make out whether there is a problem with speech which requires surgery. We call it velopharyngeal dysfunction or VPD. That's a technical term. So with perceptual assessment, hearing, so they record the speech of the child, they sit and listen carefully, and they say, look here, sir, there's some problem here, we might need a surgery. But we need to confirm that. We can't just be gung-ho and do a surgery. So we have instrumental measurements we can do. In our center, we commonly do what is called as a video fluoroscopy. Yeah, that's an X-ray when the child is talking. So we give some sentences for the child to talk, and we take an X-ray and see how it's functioning. Then we can quantify whether it is fully functional, partially functional. And based on that, today, from our own research, we have developed algorithms to decide, based on the quantum of defect, what kind of surgery has to be done. This is something we have evolved and published in the medical literature. So this is how a team works. So you rightly mentioned that it's not Krishnamurthy, it's a team. The team that includes multiple surgeons, speech language pathologists, orthodontists, nutritionists, psychologists, pediatricians, anesthetists, geneticists. The list is endless. ENT. And if somebody listens to this, they'll say you forgot some 2-3 specialty. It's like that,
Yeah, I know.
Yes.
You may forget. I
Yes,
agree.
it is a team.
All those who are supporting him, thank you very much from the studio of Rebooting the Brain. You guys are doing a fantastic work. Keep it up. These children and the parents need all the support and more that you guys are giving. So, hats off to you people.
Cardiologists,
Correct,
pulmonologists, but these are not every day.
Every day, correct.
Yeah. So this is
which means that multi-specialty hospital environment makes the stress that much less, and it gives you the confidence of handling more sicker children at the end of the day.
How our system works. Most of our primary specialists, but I'm explaining. We are on one floor across multiple rooms, right?
Correct. So
when people come to me visiting from the UK or US, they say they've never seen a model like this. Over there, what happens is that surgeon writes a referral to the speech, and then they go there, they give them an appointment 2 weeks later, and then they have multidisciplinary meetings once in a few months. But whereas we sort it out on the same day, we engage each other across the room many times a day.
System is better than the UK system.
Yeah.
I can imagine. I'm not surprised at all. So now the surgeries have been done. The child has done well. The wounds have healed. So as this is going on, how are the parents' psyche? They're getting better. They're seeing that it's not too bad. How does that go? How is the journey of the relative?
Most of the times they're very, very happy because it's a drastic change. We sometimes crib, scar is developing. It's a little peaking there, but most parents don't even notice that. Some will,
but they're extremely happy.
Most of them are. I've very rarely had a parent unhappy immediately after surgery. They might come with some concerns 3 years down the road. We'll discuss that. I'll tell you a story in this context. We talked about antenatal scanning. We talked about advice to terminate pregnancy and all. I had this one patient. They were actually related to one of our anesthetists, So he had referred us, and then fortunately my counseling worked and this child underwent surgery. So I remember coming out of the OT after doing the cleft palate surgery. Lip was done at 4 months and palate at 9 months. And they were saying, thank you, doctor, and all. Then I asked the mother and grandmother, do you think it was worthwhile not terminating? They didn't even remember that they wanted to do it.
It's good that they're not traumatized by that.
I forgot. Erased. Your mind remembers only what it
I agree with
you know that. Yeah, so they said,
I'm glad.
"Illa doctor, illa, illa, illa. Kushi agide." So
Excellent. And so that's happening. So you must be thinking, Dr. Krishnamurthy is talking so many problems. This problem, feeding problem, pneumonia problem, a surgery problem, healing problem, ear problem, speech problem, whatever, A, B, C, D, so many different specialties. So how many of these people have done well?
wow, this is a very good question. You know, in the past,
Eventually, that's the
yes,
that's the
in the
outcome.
past, we used to look at our success. We used to evaluate. We used to do surgery, and we say, "Oh, this is what I do. This is my best results." But today, the world has moved into what is known as parent or patient reported outcome measures, or PROMs. So today we use scales and indices which are given by the parents or patients themselves. How do you feel? Your speeches, how do you feel your faces, are you confident going to a party, and so on and so forth. A lot of things. And we find that overwhelming number of patients in each category, it may be slightly different. I can't quote those numbers, but overwhelming number of patients around the world, not just are leading satisfactory, contented lives.
And they're going to become IITs. I know some of them who are doctors, neurosurgeons,
Yeah, we have
and all sorts
we
of.
have a singer in Malayalam. He was a playback singer who was operated in one of the Smile Train centers as an older kid. He's a singer. And when you were doing your research, you found out that there were
Yeah,
so many
yeah.
famous Hollywood and
Yes, Hollywood,
personalities.
yes.
Jesse
So many.
Jackson.
Yes.
Yeah.
So many of them. So it's so there's nothing, no developmental issues of the brain. They do very well. So guys, forget about the thought of any of you in antenatally come across this anomaly scan. You feel there's something there. There is nothing that you should do except make sure the child comes and meets somebody like Dr. Krishnamurthy and team as soon as you're getting discharged from the hospital after childbirth. That's the starting point. And they will, there and their team will take care of the rest, and they will hold your hand all through the journey.
I'm sorry if I gave the impression that it's all problems.
No, no,
That is for my mind, but not. This is something that I tell the parents. All these things are there. Please, you don't worry. I will worry for you, because it is my job to fix it, and it will be fixed. Your child might have asthma. Your child might have an accident. They're all problems. They come later on in the life. Only thing is, this comes right in the beginning. But you have already come to the team. I have to explain to you what is involved, but don't worry, because the worrying bit is done by us.
Add your team.
Sometimes team. Sometimes we may have to debate, we may have to argue what is the best thing for the child, but that will not stop us from providing the best care. Talking about success, I want to tell one more story.
Sure.
I operated on this child whose parents of India, they work in the US, and this kid now is 8 years, and I was having, so you develop bonds with the parents, with the children, so much that you keep in touch with them.
Correct.
Even if they are
Like
in
a
faraway Dallas,
Mm.
And I got this video call from the mother. She said, my son wants to talk to you, and then he just wants to say hello. And now the thoughts have started coming to him that when he grows up, he wants to do the kind of work we are doing.
Whoa.
Yeah.
That's inspirational.
It is, yeah.
Yeah, of
And
course.
he may not become that, but the fact
The
that
thoughts
he understands that, and he might have a better future somewhere else. But that a 7-year-old is thinking that I went through this, and let me help others.
Absolutely.
That is gratification.
Those kind of things, no money can pay you at the end of the nothing.
No
Nothing.
money.
I
Yes.
agree.
Yes.
I completely agree with you, and that's the nasha for people like us.
Absolutely.
That's
That's why we continue to be evangelical or whatever else, because you understand that there is a scope for doing a lot more,
So I know him for a long time, and he is like gung-ho all the time, pushing, because the cause is what is driving him.
Absolutely.
That energy he gets from the parents, from the patient, from the grandparents. I think
And
that's
also
what
the team,
the team. At the end of the day, I think that's what keeps the whole thing going, because
Yes.
you're making such a big difference.
Everybody's invested in it. Everybody wants the child to be good.
Yes.
And everybody knows them by their first name,
Correct.
That's what makes it.
proximate.
Yeah, people are very happy.
Exactly. Modern advances.
Mm.
So much of technology has come in imaging, in this and that, AI. Whatever. How much of technology has shaped has changed the way you have approached these things at different levels?
A lot.
Yeah.
A lot.
So can you
I'll
tell?
give you a couple of
Sure.
examples. One of the things that is currently happening is what is called as virtual surgical planning, or VSP.
Okay.
Yeah. So my colleague, I mentioned to you, my former student who is my colleague, he has bought in an expensive software. He sits in front of a computer and decides what is the best surgery for this child, and then implements its commands on the surgical table. So you plan the surgery. This we do mostly for jaw surgeries right now, complicated jaw surgeries that these child may require at the end of their growth. So this may include moving the upper jaw forwards, the lower jaw backwards, because the upper jaw is not grown well, etc. So you have complex softwares which allow patient data to be fed into them, and then you sit with them, you sit with an engineer, you plan, and you get a perfect plan, and then you can make customized splints, etc. So on the OT, you just have to implement that using these whatever guides that the computer provides. Is amazing technology because you can be more precise, you save time, you get
Cosmetic results are
better
much
results,
yeah.
much better.
Eventually, it's cosmesis. That's
Yes,
what is.
yes.
I think it's worth the effort.
And it's precise. Like, so virtual surgical planning is one big thing. The other thing I already mentioned to you about scanners.
Correct.
You can scan everything. Earlier,
So what kind of scan? Is it like a handheld scan?
Handheld. So earlier we would take some sticky material, what we call impression, put it in the mouth, you're struggling to breathe, but you do it and then you pull it out and so on, and you may not get it properly. But now you're, again, this is getting recorded in the computer. You hold the scanner inside the mouth, you are watching that come in, takes a few minutes, and then you have a record of your mouth in your computer. And then from
permanent.
that, yes, permanent.
Yes.
It's permanent. You can make copies of that. You can feed it to the surgical planning software. So we have to make the plates for this molding. Today they make it. You might have heard of aligners in orthodontia. This has changed. This is a side topic, but it's very important. Some people believe that a profession called orthodontists, who put the braces and wires, might get seriously downgraded, because what has happened is today computer can decide the treatment for crooked teeth. Now we are not talking about cleft, but almost every child undergoes an orthodontic treatment where they put braces 10 years, 12 years. So today what has happened is they can scan your teeth, computer will say these are required, and as the teeth move, you need to change. They call them the aligners. So these are just plastic things, you fix it.
I see that.
Yeah. So in the US, you will see that being advertised on the commercial TV. So you can go to the mall, right? And there will be this aligner guy. He will scan your teeth and he'll send you the appliances home, and he'll say, first six weeks you wear this, another 6 weeks, and at the end of 1 year your treatment is over. Of course, it's not as simple as that, but this is caught on. This
aligner is not an orthodontist.
No, they are not. Though they say the planning is done in the lab by one orthodontist, but the company is selling it.
Oh my goodness,
now,
crazy.
Orthodontists also have become clever. They have started doing that themselves. But, this is the advantage of technology. Earlier, you had to have all these wires and sharp metal things. You look like jaws, it hurts. Now, it's just a plastic thing. You can go pick it up from your dentist or from the mall, wherever it is, and you just click it on. And so, similar things are possible with nasoalveolar molding. Instead of us preparing the appliance, aligners can be done. Hopefully, the number of visits, if we do this, one of the advantages would be they may not have to come frequently for the tweaking. Yeah, that is still not operational, but it will come on soon. Yeah, a lot of things happening with technology. Sure. And remember, genetic diagnosis, the ultimate aim will be
prevention.
Yes. That may be the most successful technology will be when they have 10 or whatever genes, and they check you whether you have that gene before you have a baby. They fix it, gene therapy. That will be the ultimate
First find
technology.
The gene, and then whether we can fix it.
Yes. And since we have found more than 25 genes, it's at present looking, but we don't know. You may leapfrog an area where 25 genes may be fixed, We never imagined we would be having machines talking in our voice.
Correct. Yes,
I wouldn't have believed, would you?
Not.
10 years ago even.
Absolutely, I agree. And with the modulation.
Technology is, we need to know what works. I don't think we should get into it foolishly because it can be very expensive.
Of course.
Yeah.
So we are going back to the psychology aspect of it. So all this is happening in Smile Train, in hospitals, in clinics, and that's one aspect of it. There's a world outside this.
Mm.
The school, the home, the playground. So what's happening there? One is the acceptance of the child, the psychology of the child. How is Smile Train also involved in educating, awareness, sensitizing teachers, children? Are you in that space also?
We are in that space, but more work is to be done.
Okay.
Because we see number of times, children who come in and parents now complain saying, my child is withdrawn, she gets teased, bullied. Many times they don't speak about it because they think it's not something. Because of this, they don't understand that they can talk to us about it. Deepesh, for example, has a very simple question to most of the kids. He'll ask, name 4 friends of yours. And if they cannot, he knows there is a problem.
Very nice.
Because
That's
they don't
like
make friends.
Very non-intrusive way of
Yes.
getting
So
this
we
conversation started.
screen them then, because sometimes they may not complain. So then whenever we feel a need, there is a issue, then the psychologist comes in. We are not able to make them as nature would have made them. Whatever work we do, there will be some minor blemishes. So what the psychologist does is shows them how to cope with that.
No, but do you reach out to the school principal?
That is something which work in progress. No, this is something we should do.
I think you should do.
Yeah, because this is now being discussed. That is going to be a humongous thing, because there's a large space to cover. But I'm sure it's possible. We are not doing it in a
technology.
Yes.
You can even make. You can also record videos and send it out.
Absolutely.
I think
Absolutely.
it may be a good idea. You giving a talk 10-15 minutes. Please play this in every class.
Absolutely.
Something like that. So
this
that
is not something that has been. I'm not saying nothing has been done, but there's a large gap here, because it's very difficult to tell a 5-year-old child, don't tease. They should understand why, So they need to understand where these children came from, because children are nice, but they can be cruel.
I agree.
Yeah.
No, and see, what may just start as a small tease will have such an impact psychologically on the growing child. It can be disastrous.
Also, we can take examples, when we do this kind of outreach to schools, etc. It is possible to tell them that these are normal people like anybody else, that with the difference, all of us are different. Somebody is a little fat, so if you're fat, they make fun of you, it's not just
True.
cleft lip. If you're
True.
Yeah.
All the time.
Yeah, you have a bat here, they'll make fun of you. So sensitizing, I think teachers are very, very important in this. I think today's generation, it's much easier because they're all technologically clued. It's very easy to pass messages to them, but I think there's a lot of work still to be done.
Like I always tell, when I go back and see my classmates in school who had learning disability, we'd make fun of them.
Yeah,
we never realized that it was a neurological issue, and I
Yeah.
felt gutted subsequently when I died.
Absolutely.
I said, why didn't somebody sensitize me to this whole thing?
I
I could have been a better classmate.
Absolutely.
I could have done something else.
I heard the word neurodivergent when I was 50.
Exactly. So I think somewhere
Yes,
somebody listening here should take it on from us, because he can't leave his OT and go somewhere else and fight all the battles.
It's important.
So we need more partners in this whole process. Education awareness is something that is never ending. I think if you can help us with
Particularly
technology,
children and teachers.
yes, I think technology and things, I think it will make the next generation that much more powerful and more gung-ho about this whole process. Are there some last messages that you want to give the audience before we close?
Right.
I think we have covered all the
I
topics.
think
I
so.
think
I
it's
think
quite
so.
comprehensive.
There is only one thing I need to tell people who may be worried about their child having a cleft lip and palate. It takes a village to raise a child.
I like that statement.
Yeah.
It takes a village to raise a child.
And we are all there. Today in our country, there are enough qualified specialists, enough good teams around the country who will take them as one of your brethren and treat you. And there are organizations like Smile Train.
It's just free.
Yeah. Completely free of cost. and
Free.
we are accountable to them. We have to upload our cases. They look at our quality, they look at our safety. Even if there is an incident that there is a problem, they will investigate it and rectify it. So we are in a space where we give lot of importance to the safety and quality of the work we do, and I don't think you should worry that you will be left behind.
Great message. What Dr. Krishnamurthy is saying is not only that there's a village available many locations. Number two is that Smile Train is there for those who cannot afford. They pay free, 100% funded. But more importantly, remember, many people think because it's free, it may be under quality.
Absolutely.
And he is saying it's world class. Where else we go? So the only question is, guys, you guys need to show up. That's it, correct? If they show up, bring the child on time, I think then the whole backlog of everything can be done. The cleft headaches can be less, and they're on well and truly on their way. Before they even get to school, everything is fixed. So nobody even sees the cleft, as they go even to nursery school, and I think that's a fantastic way. So
can I have one last story?
Yeah, of course you can have any.
So we were talking about the quality consciousness with charities like Smile Train. Today, many times I get a lot of patients who are in the private sector. They work in concerns like IBM or Accenture or Infosys or TCS or whatever. And then when I ask them, how come you're here? They say, because you're running a Smile Train and we know about it. So from charity, we are also getting private sector patients.
Excellent.
That to me is, because
Yeah,
I
the
see
proof
them
of the pudding.
Yes, I don't see that as a charity. I see that as a community insurance.
Yes.
You pay an insurance premium, you get your treatment free of cost at that point of. Here, the community is paying your insurance premium.
Correct.
From this country or somewhere else in the world, insurance premium are paid and you are getting it.
But
It's no way inferior.
Yeah. So I think it's very important because somehow people think free means
Yeah.
Something is better than nothing. It's
In
like
this
dog
instance,
biscuit.
it is not true.
Yes, I know. Of course, I can see that, but you have said it so clearly. There are 10 problems, they have 12 solutions. So remember that at the end of the day, they've dirtied their hands. They've been there, done that, guys. I don't think you should even worry. Close your eyes, get there to the Bhagwan Mahabir Jain Hospital, the Smile Train Leadership Center, or anything else close by, and they will definitely hold your hand until they need the hand to be held. I think that's fantastic, Dr. Krishnamurthy. I think you truly deserve a standing applause for what you have done, you and your team. Now it look back and say, and all of those things people can say, but at that time when the technology was not so much, they could be, the country was in a different stage. When you were not, making so much of money that you can let go, you let go of certain other opportunities, but you took this on and you really made it your own. And I think today you're looking at more and more Dr. Krishnamurthy is, multiplying, and that's, I think, is very important. You need to leave a legacy. You really have built one already. I think you just have to build it on. And we wish you all the best from the Rebooting the Brain studio for all that you have done and all that you're going on to do, you and your team. Please convey the best to them.
Yeah.
And we are with you on that. The last thing, guys, don't forget to subscribe to your channel, YouTube, Instagram, Facebook, and hit the subscribe button, hit the like button, and don't forget to comment. Because work like this, if in 2026, if Dr. Krishnamurthy is still saying people do not know what the hell is going on, including many doctors don't know what to do, the time has come for us to really make videos like this viral so it goes to nook and corner of the world. Thank you very much. Jai Hind.
Thank you, Shridhar.
Thank you very much.
Thanks a lot.
As a part of our gesture in Rebooting the Brain, we give
Thank
all
you
our
very
guests
much.
a book,
Thanks a lot.
Rebooting the Brain. Please do read it and give us
Yeah,
your...
I know about this book.
Yes, I think I haven't given you a copy.
Yeah.
Have I given you a copy? No.
I'll sit
So,
and
yes,
read
yes,
this
please.
because
It really
I've
will-
had glimpses of this. I've seen you
Correct.
release this and
True.
go around.
True.
I remember you gave one to Laligam Shekhar.
Correct.
Yeah.
He's written the foreword to the book.
Yeah.
Yeah.
So my friends
So-
worked in Seattle with him. So
Oh, he's a big guy.
yeah.
That's our next set of books that we have written called For the Judiciary of India.
Okay.
It's a 4-volume book
Okay.
on
Oh,
neurojustice.
it's all on
in
the
the sense of for the
law
I-
and
Yes,
neurosciences.
yes. Thanks for that.
Phenomenal. Yeah. This is my next read.
Yes,
Thank you
yes,
very much.
Thank you very much.
I rarely get a book from the author.
I
Thank
will also sign it for you.
Thank you.
Thank you.